تربط هذا الزوم. Okay. All right, guys, let's get started.
You're doing good, man.
We have 50 minutes or even shorter, so we'll try to cut it short. So this is the second part of the talk regarding human IV for chronic hypercapnic respiratory failure. We had part one last week that was, or this week, right? That was about COPD. I have nothing to disclose about this topic. So I will be, trying to cover some important aspects of OHS when it comes to case identification and clinical phenotyping for obesity hypoventilation, what kind of NIV that we need to choose to treat the acute and chronic hypercapnic respiratory failure in OHS, and also we'll cover some kind of the challenges that we face when it comes to the available coverage with the CMS. And also I'll try to briefly touch upon the thoracic restrictive diseases and neuromuscular disorders, just from the perspective of when to start the NIV. So I'll be mainly focusing, in this topic regarding when it comes to these two problems regarding the NIV per se. I will start off this presentation with this case, and this is actually one of the patients that I saw in the clinic. I'm still working this patient up, but I'll try to share the information that I have. So we have a 65-year-old female with 23 back-year history of smoking quit in 2003, and history of obesity, hypertension, and diabetes, who was referred for sleep apnea evaluation. Patients report history of snoring, fatigue, unrefreshing sleep, excessive daytime sleepiness with morning headache, nocturnal awakening because of gasping, choking episodes, and difficulty breathing at night. So all classic symptoms of sleep apnea. Also, patient has history of progressive dyspnea and exertion for the past 3 years that she thinks is stemming from her obesity and weight. She doesn't have any history of leg swelling, wheezing, chest pain, or any prior cardiopulmonary problems. On exam, patient heart rate is 89, breathing about 19 times a minute. Oxygen saturation 92 room air. Blood pressure slightly on the high side. She's obese, BMI 45. She's short and, had a obese short neck. Malambati class 4. She had trace ankle edema bilaterally. Normal vesicular breathing, no chest wall deformities, and the neuro and CVS exams, they are remarkable. Labs from 3 months ago done at her PCP office. TSH was within normal limits, and her bicarb was 33, and her hematocrit 49. So, Mahmoud, what do you think so far? If you just, try to digest all this information and try to come up with differential regarding the labs, exam, and also the history findings. What's your differential?
OSA, OHS, basically because of like she has chronic respiratory failure based on the bicarb. And OSA, OHS, because all of the symptoms goes with OSA. And
yes,
with the obesity and bicarb goes with OHS.
So you think maybe OSA plus minus OHS, and OHS that made you think about it is the bicarb?
Yes.
Okay. And what else that you might be concerned of? COPD, okay.
So the hypersomnia.
COPD to explain the dyspnea, right? As part of the dyspnea. Okay, maybe.
And the hypersomnolence is likely because of the OSA, but those other rare stuff is not in the picture.
Yeah, I mean, I didn't give you here this information, but nothing in the medication that can explain the excessive daytime sleepiness.
Could be heart failure on top of that.
Okay, heart failure.
Core pulmonary.
And core, what made you think about core pulmonary here?
The RV failure.
Hematocrit. Okay, so it is slightly on the high side. I think the cutoff maybe for females 47 or something like that, but slightly on the high side. Okay. So which of the following findings suggest that this patient is at low risk for obesity hypoventilation syndrome?
Low risk.
Yes, severe OSA on BSG, serum bicarb of 25, PMI 45, resting daytime of 92% or more. It is number 2. Okay. So why you think it's number 2? What is the cutoff? Yes, this is 27. Correct. So is there any specific, let's take it that way. So if it is more than 27, what does it mean? We don't have to do ABG to confirm.
No, we need to have a CO2 more than 45.
Give some clue if there is any suspicion.
Okay.
Yes, and then
What are the situations where you will be kind of wondering that maybe this is false positive? And unfortunately, I've never seen this. It doesn't help us all the time, but it's when it comes to sensitivity, it's not bad. 92%, right? So for and everything is referring to PCO2 more than 45. So if you're, bicarb is more than 27, so it's very sensitive, but it's not specific 50%. It's a flip of a coin. Like if you have someone on diuretics, steroids, stuff like that, that can be, elevated as well for other causes not attributed to the respiratory failure. If it is less than 27, there's a caveat here. So there is a negative predictive value of 97%, which is good. Okay, so if it's, let's say that we don't want to stick people and send them for ABG, especially like in clinic and stuff like that. But if it is less than 27, provided that you have low to intermediate suspicion of OHS, you do not have to do ABG. But if the patient looks very classic for OHS, even if you see that their bicarb is less than 27, you still need to do the ABG. Okay, so it's only helpful to rule out the daytime hypercapnia of more than 45. It doesn't rule out OHS. I'm just trying to help you. Can we use the bicarb in lieu of using or doing ABG? Okay, only it is very helpful and it has negative predictive value if you have a low to moderate likelihood for OHS. So you have to use it with that caveat. It helps sometimes. Okay, so there we go. You have your ABG. So as you see here, so borderline hypoxic, it's okay, or Romer, at least she doesn't qualify for oxygen for now. She's in the office. I got this after she left.
Yeah.
And remember that her oxygen SAT is 92 or Romer. So whenever you see that, that should make you think about maybe something going on as far as like chronic respiratory failure. It's on normal, but it's on the low side. What kind of sleep testing you should order for this patient? Home sleep test or in-lab study? Home. Any other idea?
Pre-test probability is high.
What is that?
The pre-test probability is high.
Okay. And the home test is helpful in that regard, right?
Yes.
Okay.
she doesn't have any comorbidity.
Yeah, that's what
You
I'm
have be
trying
on
to
lab.
mention.
But
What are you suspecting here?
Yeah,
Healthy
OHS.
lady,
Yes, no, only diabetes, hypertension,
Yeah,
and obesity.
You need to be in lab, I think.
Yes. So, I mean, it's still some. So even in ASM, I mean, it's not like very high grade, like level of recommendation. But home sleep test. So first of all, we need to use it in the appropriate clinical context. If you think that your patient has high likelihood, then you go for it because it tends to underestimate your sleep apnea. So if you're starting from a low probability, then you will miss it. But if you're starting from a high probability, you will catch it. Okay, so make sure that when you do it for patients in clinic, if your home sleep test is negative, so this is not the end of the story. Okay, so you need to do a BSG to completely rule that out. This patient actually wanted to do the home sleep test, but I recommended against that, and I convinced her to do the in-lab sleep study. So here, if you have a BMI more than 40, if you are suspecting some kind of significant nocturnal desaturation, especially like with a borderline SAT, and especially when I saw, I mean, I didn't even have the, ABG when I saw her, but I knew that there should be something in her ABG that, doesn't look right. 69 or Romer doesn't qualify for borderline. So when she will have the BSG, most likely she will desaturate. So if you have someone with comorbidities, of course, CHF, AFib, chronic respiratory failure, don't do the home test. If your BMI more than 40, actually it was, even validated for BMI less than 40, but usually like more than 40, 45, we should not be doing, especially like with the chest, belt. And what do you think, Mama? I think it's the,
So
especially,
Yeah, the cutoff
the way I would think about it is the other way around. What are the patients or candidates for a home study? Our only patient, the recommendation is patients with suspicions of moderate to severe sleep apnea. If you think there's any superimposed issues, like this patient who was worried about obesity hyperventilation, then you would not, then that's a home study is not the candidate. So you said, does she have any comorbidity? She does not, but she has concern for sleep apnea, but she has strong concern for obesity hyperventilation because of what we said. That immediately puts her, and you can see at the very end, it says sleep-related hyperventilation. So if you suspect obesity hyperventilation, then that's what we recommend. If there's concomitant COPD, overlap syndrome, they need to come to the lab, CHF and things like that. And sometimes you say low to moderate suspicion for sleep-related. Having said that, the insurance will always give me an issue. So depending on the insurance. But if you forget insurance, just think about it. Anyone who has moderate to severe concern for sleep apnea with no comorbidities, that's what a home study. Everyone else gets should get an lab study.
okay, clear? All right, so this is her PSG. So she had a severe sleep apnea from what you can tell, HI more than 52. What is the cutoff, Saddam, for sleep apnea? I mean, how we classify based on HI?
So the mild up to 11, I believe, right?
Mild up to 11, okay. 15 to 30, more than 30. Okay, so she has severe, right? And the concerning thing is the level of desaturation. So she has a significant nocturnal desaturation, almost 2 hours, less than 88, with a nadir of like 66. So based on the information that we have thus far, is there any other testing that you need to get in order to, further establish the diagnosis of obesity hypoventilation? Because we're suspecting that she has it from the information that we presented thus far, but there is some things in the presentation and the patient history that will make us also consider other causes for chronic respiratory failure. So what do you want to get for this patient?
Echo.
Echo. And what else? PFD.
She has lab. I think
We have these. So echo, BFT. What else? Maybe helpful. Imaging. I mean, it's not necessary, but there is a long there is a list of differential diagnoses that you need to rule out. What are the differentials that you will be concerned, Katie, to rule out in this patient? Because that will help what kind of test that you need to get. She's a smoker, by the way, ex-smoker. Okay, emphysema, COPD. Okay. Okay, right-sided heart failure, pulmonary hypertension, whether that's related to this or not related to this. Okay.
That's not something that would come up in a CT though. If
So,
the imaging you're talking about.
and obesity hypoventilation. So this is in particular for this patient and also for other patients. So we have to consider the other differential diagnosis for chronic hypercapnic respiratory failure. So we said COPD, we said congestive heart failure, but also we have to think about, chest cage deformities, restrictive lung disease, especially like if you have kyphoscoliosis, if you have neuromuscular dystrophies, stuff like that, any muscle weakness. I mean, you don't have to do like EMG or anything, but at least you make sure that you have a thorough exam. You looked at the patient chest, examined it very appropriately, did, thorough muscular, or neurological exam to make sure that you're not missing any kind of, muscle weakness, because that can explain some of these findings. So this is what I did for this patient. I did CT, PFT, and echo. So for the PFT, so Ramsha, read this. How would you read this?
So FEV1 is lower than the lower limit of normal.
the ratio is higher than the lower limit of normal mortality. And
This is normal. We read that either normal ratio, right? Okay.
Yes. And FPC is also lower than lower limit of normal. TLC is that is higher.
So if you look at that and stop,
yes, so,
there is, hold on, obstruction or no obstruction?
So if it's normal and there's I think that there is no obstruction.
No obstruction. Okay. At least it tells you there's no obstruction. Okay. So look at the rest of the other numbers.
And then DLC was also low. So
Okay.
I'm thinking the FE1 is set. It's a non-specific pattern.
Yes.
With moderate.
Mhm.
Okay, at least looking at TLC, there is no restriction. So, I mean, as you said, non-specific pattern. So there is no restriction by TLC criteria. There is no obstruction, right? And what else? Look at. We don't pay attention to it because it's not important most of the times, but
Corrected.
you see ERV is low, right? 20% of predicted. Your FRC slightly low as well, right? Okay, and your DCO is low. So some non-specific, pattern of, reduced FVC and FEV1, but there is no clear obstruction or restriction, and there is some moderate, diffusion impairment, right? Would, at least from what I can tell, ERV that's, significantly reduced out of proportion to the rest of the lung volumes. So this is what we see in obesity. So when they looked into 376 patients who are actually less than 10 pack year history of smokers, it's a normal, they were like trying to collect data to know what kind of, impact does the, PMI have on the lung function and the lung volumes. From what you can actually see here is the FRC and ERV, they were like significantly impacted by the PMI, with the ERV being the most affected, and also, the FRC from what you can tell. But for the rest, like, of the other volumes, they were like mostly within the normal limits, at least for this, study. So whenever you see the ERV that's out of proportion, reduced to the rest of the lung volume, so that makes you think about obesity to be the cause, especially like with that non-specific pattern, because that can be early obstructive lung disease, that can be due to emphysema, can be due to sometimes even some forms of, poorly controlled diabetes. Sometimes even the obesity can explain this, but especially if you have the ERV that's out of proportion, reduced to the rest of the lung volumes. This is CT, didn't show me anything significant like, emphysema, or maybe there's a little bit of, centrilobular, very, very mild. There's nothing. But if you see on the mediastinal window, the, PA to aortic ratio is definitely more than 1. So that makes us think about pulmonary hypertension to be another possibility for this patient. Correct. Have any questions?
Is this like prominent vessels in the right lower? Can I
Right.
call them prominent? So the right and the
Lower.
the CT scan, it's normal.
Honestly, like, I mean, I need to scrutinize the, CT scan, but I don't think that there is significant. And
Another clue on the PHP,
Sure.
if the corrected DLCO to the alveoli, if it's normal, that will give us that might be secondary to the obesity, right?
what do you mean?
Like the ratio DLCO to VA ratio.
I mean, you it's very controversial. You'll see like a lot of people believing or not believing in this, but that tells you about the lung volumes itself. So if it corrects based on the lung volume, whether that's the obesity or something
It's
else,
against the interstitial lung disease.
Again, yeah.
If it's connected with the-
Yes.
so there's-
relative to your
it's
volume.
not like- It's not with interstitial lung, but we don't know exactly what's wrong. But that tell you that there is no interstitial lung disease causing this drop in the DLCO.
If it's restricted, okay.
When you account for the alveolar ventilation, yes. So this is just to sum it up. You always need to think about this triad: more than 30 BMI, awake. Believe me, sometimes it goes unnoticed, even in clinic. So you have to keep low suspicion for it, because treatment, especially when it comes to what kind of treatment, and especially with the NIV part, as I will explain to you, it will be somewhat different from the other causes of obstructive of chronic hypercapnic respiratory failure. And those are the list of the differentials that you need to keep in mind that you must look for in your investigation, your exam, and history as well. Other ancillary finding that may help you, but you don't necessarily have to have them, especially like if you have unexplained, SpO2 that's borderline less than 94, any nocturnal desaturation less than 80 with a nadir less than 80, that makes you think about it. Nothing that's very pathognomonic or specific. If you have any element of pulmonary hypertension or some facial plethora and polycythemia, this patient had, the hematocrit on the high side. And of course, the bicarb more than 27, but you have to use your judgment. So this is actually a very important slide that tells you what kind of, sleep disorder breathing that we have associated with sleep apnea. So the first, pie chart that you see, 90% of patients with OHS, they have, coexisting sleep apnea, 90%. So this cohort is easy to identify, right? No one usually will miss them, but yeah, sometimes the other 10%, it can be tricky. You don't have to have a sleep apnea with OHS. It can happen with, obesity or what we call sleep-related hypoventilation. But almost 100% of obesity hypoventilation syndrome, they will have some sort of sleep disorder breathing. It doesn't have to be sleep apnea. I'll explain to you on the next slide what I mean by sleep-related hypoventilation.
So the AHI
What's that?
negative for these?
Yeah, you may have, and I will explain why as we go. So 90% of the time, it will coexist with sleep apnea. It's not like a mandatory criteria. It's not like among the triad, but it makes it more, likely, right? So, but keep in mind that 10% of the time, you may not see obstructive sleep apnea. But that doesn't make the diagnosis unlikely. You have to keep in mind the obesity or the sleep-related hypoventilation, and I'll show you how to test for it and what's the definition for that. And on the other hand, if you see the obesity, the sleep apnea patients, only 10 to 20% of them, they will have, obesity hypoventilation, and the rest, they will not, even if they look obese, because, not everyone with, OSA will have sleep apnea, but the reverse is not true when it comes to the OHS. Okay, so you have to keep that in mind. All right, so the prevalence is increasing. We don't really know among the obese patients, but it's anywhere between 8 to 20% of obese patients in the US. They have some element of obesity hypoventilation, but definitely with the PMI increase more than 50 is 10 times fold increasing in the US and then in the last few years. So that will actually translate to more cases of obesity hypoventilation. But the exact epidemiology, we don't know. So back to our case. So in addition to weight loss and lifestyle modification, what the next step actually is going to be for this patient? CPAP titration study.
CPAP.
ABAP 5 to 20, BiPAP titration, AVAPS titration, or you just prescribe this patient, BiPAP or AVAPS. CPAP. Okay. Everyone is in agreement? CPAP.
I think you start with CPAP.
Yeah, you start CPAP for OHS.
Okay, all right. Good. So I didn't trick you for this. Don't use ABAP for OHS. No. It's not approved. Okay. ABAP, not for OHS. Okay. So we start with CPAP first, and there is a reason, and I'll explain to you in the next slide. So this is the definition of obesity hypoventilation. I don't know why I say obesity hypoventilation, sleep-related hypoventilation. So you don't need to know this in details, I think, for your pulmonary report, but you need to, for sleep, of course, but you need to know what it means. So either when we do the sleep test, we check the ABG, which is not what we do in real life, it's just only in research. They do transcutaneous PCO2 monitoring, which is a reliable, somewhat surrogate to the PaCO2. If there is increase in 10 millimeter mercury above 50, increase of the CO2 above 50 by 10 millimeter mercury from the baseline for 10 minutes, okay? So this meets the definition for sleep-related hypoventilation. For patients with already some form of hypercapnia, okay? So any increase of the CO2 more than 55 if it lasts for more than 10 minutes during the PSG. So if you need to particularly test for this, so when you put an order for your sleep test, I have yet here to see it, but they don't do it here. So you have to order like with transcutaneous CO2 monitoring. Regular plain ABG doesn't tell you about this. So this is why if you still strongly think about obesity hypoventilation because the patient doesn't have muscle disease, restrictive pattern like from the or kyphoscoliosis, everything is pristine on the CT scan, no emphysema, nothing, and obesity, and you did the sleep study and it came back negative, and it's like, well, since the sleep study is negative and I don't think this is obesity hypoventilation, this might be something else. You still need to test for this. So your sleep test will be to test with do a regular PSG with transcutaneous CO2 monitoring. We don't do it here for everybody because most of the time you will pick up the sleep apnea. You don't need to worry about this, okay? But this might be an issue if you order a sleep study and it comes negative and you're still convinced that sleep OHS, explains everything. So then this, particular, finding or this particular type of sleep disorder breathing might be the case. And it has some therapeutic implication, and I'll tell you about it later on.
That is the standard for diagnosis?
No, I mean, you have OHS, but with underlying sleep-related hypoventilation. But most of the time, you will say OHS with underlying or coexisting OSA. Okay, because the treatment will be different in these people, okay? So for severe sleep apnea and OHS, you start with CPAP. And this is even, the most recent recommendation still actually is weak conditional, but this is what we have to go by, especially like with the 2019 ATS statement about obesity hypoventilation. You start CPAP and you reassess in 2 to 3 months. And this is what you need to do when you see the patients. Make sure you check their nocturnal oximetry while they're on CPAP. Make sure that their hypoxemia resolved. You check their daytime PCO2 after at least 2 to 3 months of being on CPAP. Ask for any admissions related to heart failure if they're still decompensating despite CPAP. So that tells you that your treatment is failing. And you assess for the symptoms that they are non-specific, but they can tell you a lot about the chronic hypercapnic respiratory failure. Morning headache, nocturnal smothering at night, sleep fragmentation, excessive daytime sleepiness. So you need to assess for these symptoms when you see the patient because they are, they are one of the parameters that you will be looking at when it comes to you assessing the, efficiency of the CPAP or whatever, PAP treatment that you're using to treat the hypercapnic respiratory failure. If, this succeeds, okay, most of the time it will, but if it doesn't, or the patient doesn't tolerate the, CPAP, then you go to the next line, which is, either, a BiPAP spontaneous, the regular BiPAP, or BiPAP ST. So for the AVAPs, it's a whole different topic, but I'm just giving you, the bottom line here. The efficacy of AVAPs equal to the BiPAP ST. There is little actual data to support the use of one over the other, but when it comes to the insurance, getting AVAPs is easier. And I'll explain to you in the next few slides. Of course, the oxygen, you need to start them on oxygen if they need them, if they need the oxygen, but there's a chance that, especially for borderline, hypoxic patients, once you get them on BiPAP treatment, they lose weight. So after a few months, they may not even need the oxygen. So you may need, even in the future, to test whether or not they will still need to be on oxygen, especially if they respond to the, PAP treatment. This is a very important slide because you have to be aware about what are the clinical phenotypes of OHS, because that will dictate who will respond to CPAP and who will need, more kind of NIV kind of treatment. So when we sleep at night, so most of the time, we will have, some kind of degree of upper airway collapse, but it becomes more clinically evident in patients with, OSA. So the upper airway resistance that increases at night. So this is definitely contributing. And as you see here on the top, it's not very clear, but patients, they have a lot of parapharyngeal fat, and when they lost weight, so that kind of, fat actually goes down also, and it will actually, make the throat more open at night. When we sleep also at night, so in supine position with a distended belly, a lot of abdominal fat, so that's actually pushes on the diaphragm, causes, bibasilar atelectasis that contributes to the VQ mismatch as well. And also there will be some kind of muscle weakness that was noted in obesity hypoventilation patients, and that will be even worsened further during the REM sleep. Everything is worse in REM. REM is when your muscle tone goes to the bottom. So upper airway, more obstruction, diaphragm more weaker, intercostal muscles. So your ventilation will be compromised during the REM sleep. And as you see, so your FRC goes down, your ARV goes down, when during obesity. Okay, so that's comparing the lean to obese patients. Also, there will be some form of premature closures of the airways in obese patients. Okay, they have some kind of functional. I'm not saying obstruction that obstructive lung disease, but a functional air trapping. So because of the all less compliant chest wall, so the small airways, they will tend to collapse earlier. With that will result in some form of air trapping, and that will increase the intrinsic PEEP, and that can also increase your dead space and worsen your ventilation. So there's multiple things that can cause the ventilation to go down when we sleep. And one of the also most important things, in addition to the upper airway and the changes in the lung mechanics that can happen at night, is the decrease the central drive to breathe in obesity hypoventilation. I'm not talking here about medications or anything but even in obesity hypoventilation, they have some kind of leptin resistance, and leptin is one of the neurotransmitters, kind of hormones that works in somewhat to increase your ventilation at night. And when you have a resistance to that, similar analogy to type 2 diabetes, so your ventilation, it will drop at night. It's central ventilation. Okay, so that's also something that's contributing to the pathogenesis of obesity hypoventilation. What you see, so now you digested this and you know what happens or why people, they hypoventilate at night when they have obesity hypoventilation day and night, but it becomes more worse, of course, at night. Is what you see on the right side is what dictates which part of the abnormality that I described to you in the pathogenesis is the most predominant. Sometimes you will have obesity hypoventilation patients whose their problem is mainly in the upper airway. Okay, once you fix the sleep apnea with CPAP, everything will get better. Okay, sometimes you will have the problem is not just only in the upper airway. The main problem or the predominant problem here is the leptin resistance, or maybe blunted ventilatory response to elevated CO2 when we sleep. So those patients, even if you fix the upper airway resistance with CPAP, they don't respond well, and they will still need some either more oxygen, or they need maybe more NIV, some more advanced form of NIV. So this is why not everybody will respond to a CPAP, and this is why also we don't have to use advanced NIV for every patient with obesity hypoventilation, even if they look hypoxemic and they look bad. So don't get me wrong, we still need to CPAP. Sometimes it can work. Okay, so even if the person they look obese, sometimes they're borderline setting or hypoxic, we still need to start this and reassess in 2 to 3 months. And this is why we don't think that CPAP works for everybody, because of the different clinical phenotype. Like COPD, we have emphysema, we have mixed, we have chronic bronchitis. Same thing actually applies for obesity hypoventilation as well. So if you have obesity hypoventilation, you have severe more than 30, you just go with the route of CPAP. You try the CPAP and assess everything is okay, stay on the CPAP. Not working, then you go to the NIV. Okay, and there is also here is a controversial, like what if you have sleep apnea that's not bad, like maybe 15, 16, somewhere, but mild to moderate. So should we try CPAP? It's controversial, but definitely if it's mild, less than 15, usually these patients, they don't respond because I told you they have obesity hypoventilation because of the other problems, because of the blunted response to ventilation, or because of some leptin resistance, because of some significantly impaired lung mechanics where you need some some sort of pressure support and NIV to help. CPAP alone is not going to fix it. Okay, so if you have more than 30, you go with CPAP. Less than 30, I think you can go either way. What I do, and I think this is easy, we'll come back to that. So if they have obesity, hypoventilation plus OSA, do titration and see what happens, okay? First, before you decide on which treatment. And usually request the CPAP titration, especially if you have more than 30 AHI. So this tells you that, the CPAP or whatever PAP therapy that we select, it helps to decrease the level of hypoventilation, and also it helps to decrease the pulmonary hypertension as well. So it improves the pulmonary hypertension, improves the daytime and the nocturnal also ventilation as well, and we have to offer it in a multimodal kind of therapy with the lifestyle modification and diet, because the PAP therapy, it may help with the symptoms related to the respiratory failure, makes your gas exchange better and improves your RV hemodynamics, but it doesn't fix the other comorbid conditions and the metabolic problems. So this is why it's PAP plus weight loss. These patients, they might need to be referred for like bariatric surgery. They need some intensive, dietary changes and stuff like that. So always offer it as a bundle, not just only, PAP therapy and you forget about the weight and the lifestyle modification that you need to do. So we'll come to a more kind of comprehensive approach in the last couple of slides. So let's take this case. So 52-year-old lifelong non-smoker patient who is morbidly obese with a BMI of 53, with a history of hypertension, diabetes, hyperlipidemia, was admitted because of worsening dyspnea and leg swelling. Dyspnea on exertion for the last 2 years, worsened in the last couple of weeks. Patient had a history of PND, fatigue, palpitation, loud snoring, daytime sleepiness, and witness apneas. No wheezing, cough, any prior cardiopulmonary problems, no history of similar admissions. On exam, patients tachycardic, tachypneic, hypoxic, 86 on Romaire, hypertensive, and also, sorry, the BMI is a mistake. It's a 53, not 37. Cyanotic with ankle edema, +2 bilaterally. There is some, crepitations, no chest wall deformities. He has a Laudis 2 with no focal neurological deficit or weakness. So the initial ABG, 7.21, 67, and 60, and that's on Romaire. ECG showed some new onset AFib, and he had some mild LVH. They did CTBE when the patient came to the ED. So of course, it didn't show any PE. There is bilateral pleural effusion, some bilateral ground glass congestion, some pulmonary edema kind of picture. No emphysema or ILD changes noted. Echo, increased left ventricular film pressure, mildly dilated LA, finding that goes more with diastolic heart failure, and also possible maybe pulmonary hypertension based on this. So the picarb was 35, and this patient is not on diuretics. UDS is negative, and TSH is normal. So what do you think, Anthony? Quickly, that we're dealing with.
Pulmonary edema causing the hypoxemia.
And it's a new onset, right? Because this patient is not known to have any cardiac problems. First time to be admitted with this problem. First time. You need to remember this. Okay, after treating for diastolic heart failure and whatever, AFib, and instituting, of course, the acute NIV to treat the acute on chronic hypercapnic respiratory failure. What is the most appropriate next step upon discharge? Hamza, you want to give him AVAPs?
Acute.
What's that? You said AVAPs? AVAPs, right?
Fraction is normal, so that's they have to pay attention that ejection fraction more than 40 or 45.
Is it relevant to AVAPs?
Just to servo.
This is for ASV.
For ASV.
Mhm. This is for ASV doesn't provide you with any, so ASV is just stabilize your breathing. So people, when they have, they become hyperapneic at sometimes and they wash out their CO2, they become apneic and they have sleep apnea. And so it's just stabilizes your breathing. Okay, so if you're hyperventilating, it's not going to give you more pressure support. It will decrease its pressure support. If you have more kind of sleep apnea and obstruction, it gives you like more support to help with your ventilation. So that's the ASV. We need to avoid it if the EF is less than 45, but the AVAPs is not ASV. It's a completely different mode, okay? So
Sleep study.
you said ambulatory sleep study when we discharge the patient. Okay. I think I'll give this patient and you will know the answer. It is controversial, but there's some data about this, okay? And I'll show you why. So this is from the most, and even this data actually dates even back to like several years before this paper, but this is the ATS paper about the obesity hypoventilation. So they did a meta-analysis where they, requested, data from different, 7 retrospective studies with more than, 1,100 patients who actually was admitted with either confirmed or suspected obesity hypoventilation. 10% of these patients, they were discharged without BAP. BAP, that means either NIV or CPAP. And 90% of these patients, they were discharged on some sort of PAP, and 92 of those, 90%, they were discharged on NIV. NIV, that means either BiBAP or BiBAP-ST or AVAPs, okay, not just only. So they were discharged with some kind of positive airway pressure, kind of ventilation. When they looked at their mortality adjusted for age, sex, and baseline CO2 at 3 months, you can see the significant difference. Okay, so this data is from retrospective studies. We still don't have, randomized prospective trials, and even there's like multiple, retrospective studies. But this is the best that I found that actually showed some mortality benefits. So this is why when you have people, coming here with some decompensated heart failure, and either this is the first time for them or they are coming multiple times, when you have high clinical suspicion for obesity hypoventilation, is you discharge them on, so this is different from COPD. Again, so even the level of evidence for this is low, but I think from the data that I just showed you, you're not going to be hurting the patient. But this is not a destination treatment. This is not something that you will send them on. So like you will stay on this to the rest of your life. You just send them with a plan to do BSG in 3 months. What if you do and you have severe sleep apnea? Then, okay, I'll switch to CPAP and treat them. And the reason that we are doing this is we are trying to decrease their mortality because they are getting admitted next time. And who comes next time? They come here, maybe they wait too much, they get intubated, hypoxic cardiac arrest, because we don't want people to come with another flare-up of their, respiratory failure. But this is not meant to be definitive. This is to decrease until we get more data to know about these people. So it's recommended that you do that. This is different from someone who's coming with COPD for the first time. So I think you got confused about that point. For obesity hypoventilation, it's the other way around. So again, these are 2 studies. If I remember that I told you last time, stay tuned for this. So it's really amazing that I thought that's just only maybe us here, but I think it's this is a national issue actually, is to mislabel people with COPD when they don't have it. So this is a study done by, I think, Paul Merrick is the, critical care guy in Eastern Virginia. So they looked into their malignant obesity hypoventilation syndrome and people who are admitted to the ICU with either provisional diagnosis of obesity hypoventilation. So when they looked into about 61 of acute and chronic hypercapnic respiratory failure met OHS inclusion criteria, 75% of them, they were incorrectly diagnosed with COPD and asthma, despite the absence of obstruction on PFT, okay? So that tells you it's a problem. Obesity hypoventilation, this is why sometimes it gets underestimated, even if you smoked like 1 or 2 years during your adulthood, as long as it's positive in your history, then you have COPD, no matter of what proof you have later on to, you know, say the opposite. And also in that cohort, 85% of them, they were treated as CHF. I think it's okay to be treated as CHF because this is the main problem here, but we should use the correct term, okay? And also obesity hypoventilation, this is, or obese patients, very interesting data also from 2014. Patients or overweight and obese patients are more likely to be given a misleading diagnosis of COPD and not to have their inhaled treatment de-escalated after spirometry, demonstrating no airflow obstruction. So the obesity or obese patients not only actually were giving or mislabeled as COPD, but they were also at less, you know, they have less chance of having the unnecessary inhaled therapy to be de-escalated. So this is a problem. Sometimes when you have admit these patients, if their main problem is CHF, you manage that. It's not just to give them inhalers. You will see them in clinic admitted for whatever, and you see like a Spiriva, Symbicort for whatever. I mean, for what? So always like, don't get, you know, kind of, you know, confused. It is a problem that, and this is a, by the way, it's more than 1,000 something. This is a VA study. So it's a problem. So it is okay to, you know, stop inhalers. If you think this is all obesity hypoventilation, you don't have to continue them unless there is some other, you know, legit reason to continue this. So you have to keep that in mind that obesity hypoventilation, you may see them also in inhalers.
Was there a different?
I think in that study they were using a PMI for that study, not 30, I think 40. Okay, but the rest will be. Nothing that I found is, you know, significantly different other than having, so you should have, I think based on that study, some RV dysfunction on echo, and the BMI cutoff that they use is 40.
Higher.
I mean, if you want to use 30, most likely they could have recruited more patients, but they use a BMI of 40 for that study. But it's a problem. So when you see obesity hypoventilation, you might see some other inhalers. So if you think that they don't need them, stop them. So this is, again, I hate this CMS thing when it comes here, but this is if you want to go to the route of, which I don't think that you have to do that, because 90% of the time you will have sleep apnea. You'll go with the route of sleep apnea. So it's different from the COPD, but if you don't have sleep apnea, and that can happen to you 10% of the time, so you have to decide how you're going to treat them. So unfortunately here, so they have you to first prove that they have daytime hypercapnia, and here it's 45, by the way. Don't confuse it with the 52 for COPD. Hypoventilation cutoff is 45. You have to meet that, plus you have to have a spirometry, and this is a requirement. You should have this. It's not like the other one for COPD. You don't have to have a proof. You don't have a sleep apnea is not the issue, but you don't have to test them here. You have to have a spirometry. Okay, so and that will delay your treatment, because if you want to wait until they have their spirometry and stuff like that. And the third box is you have to prove that also that these patients, they have some elevation in their PaCO2 when they are sleeping or immediately after waking up by more than 7 millimeter mercury from the baseline. Let's say their baseline is 50, then after they wake up in the morning, it's 58, 57 or more. Okay, or you will have evidence of a sleep apnea test that showed that they're still desaturating more than sat more than or less than 88 for more than 5 minutes, with no evidence of sleep disorder breathing. It's a very rigorous and stringent criteria. And even after you do this, and guess what? What is EO470? I brought it for you down here because you might need it when you go for private practice, especially if you get these terms and you get confused about it. And this is just only regular BiPAP. That doesn't provide any guaranteed minute ventilation, some sort of regular BiPAP. Okay, this criteria, it's also failing to acknowledge a lot of things. Failure to recognize the disease severity, because not everyone will respond to CPAP. Some patients, they will require more intensive form of ventilation at night. It is very difficult to meet their requirement, and also for DME to continue to pay for this. So these patients, they need to be seen in a timely manner, 61 to 90 days, and have their physician to attest that they are using this treatment and blah, blah. So these are very, very kind of, stringent criteria actually to meet. And if you want to provide them with AVAPs or BiPAP-ST, which is not a home vent, by the way, here we go directly to the home vent and I will show you. But if you want to provide them with AVAPs or BiPAP-ST device, which is something that they label as EO471, that's in equipment. It's an abbreviation for equipment and the national coverage determination CMS kind of guidelines. So if you want to qualify your patients, then you have to prove to them that first they use whatever BiPAP that you gave them for X amount of time, and you have to prove that they're still hypoxic and they are still desaturating despite using the the BiPAP. So if you meet all that kind of stringent difficult criteria to meet, then they will give you the AVAPs or BiPAP-ST. Very difficult to get through this, and I don't know why they still have the oxygenation to be part of the treatment. So you have to be on the BiPAP and oxygen at the same time, because being on oxygen doesn't fix the ventilation part, and there's zero evidence for this, and they still have it on. So what we do, and there's no clear actually guidance from the CMS on when to request the home vent, which is the trilogy here, which is the Philips Respironic, is part of the home vent. We just go straightly justifying that patients admitted more than once with acute and chronic hypercapnic respiratory failure, or they continue to have, PaCO2 more than 45 despite being on, BiPAP-ST or AVAP. So you go directly to that, and this is what gets them. And by the way, this is or this kind of approach that not us doing, but almost everybody, because of the stringent criteria, people, they started to inappropriately prescribing home vent, because you don't have to need that fancy machine, the trilogy, just to provide BiPAP-ST or AVAPs, right? But they just made it difficult in such a way where the only way that you get them the treatment that they need, if you go to the route of home vent. Home vent, by the way, patients, they will continue to pay every month. The other machines, AVAPs, BiPAP-ST, CPAP, BiPAP. So there's, after 13 months, there's a cap for their payment, so the machine will be theirs. And but the problem with those devices, they don't provide any respiratory support and stuff, like if they need to come at home and do some kind of mask fitting, stuff like that. When you have the home vent, it's covered under the DME, but they will continue. There's no cap, so patients, they will continue to pay for this, for the trilogy. Okay, so it's expensive. So why would we give the patient expensive machine? Because this machine can operate on 13 modes. Okay, give me a machine that can operate on 2 modes, and I need one of them. I don't need the other. This is the simple way to think about it. But I think now they're actually group of experts submitting proposals to the national coverage determination people, along with the CMS, to convince them that what we are doing right now is not evidence-based, and we have to switch to a different form. This is actually what they suggested, this group of expert panel. This is not guidelines, guys, but I just want you to look here. So if someone comes, obesity, hypoventilation, hospitalized, discharge them on VAPs, BiPAP-ST, okay? Here, whichever you can get them approved, either like you give them trilogy, if they can get this, we are good with that, okay? With the AVAPs, just only AVAPs machine. And you have to do a sleep test within 3 months. And based on your sleep test, you refine your treatment, okay? Based on the data that I told you. It's still suggestion, it's not, set in stone kind of approach. If, by any chance, by the way, I didn't tell you anything about that, but you have to keep that in mind, that obesity hypoventilation is part of the hypoventilation syndromes. So especially here with the drug epidemic, sometimes, I mean, it's all drug related, right? So if you have obesity hypoventilation or chronic hypercapnia due to some form of hypoventilation other than, the obesity hypoventilation, like if your BMI is less than 30 and you have drugs on board and maybe some other kind of lung disease, that may be contributing to this, then CPAP is not going to be your treatment. So you need to go strictly to the NIV part, like using AVAPs or BiPAP-ST. And if you have what we alluded to earlier, the sleep-related hypoventilation, CPAP is not going to help you. So you go directly to NIV, which is BiPAP-ST or, BiPAP or BiPAP-ST or AVAPs. If that's all failing, then you just, prescribe them home mechanical ventilator. But what we do in real life, I think everyone goes to the home vent because it's easy for us to get. A couple of slides about, and I think I'm done after that, thoracic restrictive disease. I mean, this term, can include both neuromuscular disorders and thoracic cage abnormalities. So if you have like any problem, the way that I think about it is starts from your brain and ends with your muscles. If there's something with your brain, like maybe injury, maybe nephronic nerve injury, any spinal cord injury, any, peripheral neuropathy, any kind of, nerve damage from Guillain-Barré, neuromuscular disease like myasthenia gravis, or some sort of myopathy, whether that's inflammatory or dystrophic. So you'll see a long list of, indications, but I just want to make sure that you all aware about this, because sometimes you will see them in clinics and you'll see them in the hospital. Patients who are coming with some sort of hypercapnic respiratory failure, and obesity hypoventilation is not the case in them, and you think they have either neuromuscular disorder or thoracic cage abnormality. So those are the indications to start them on NIV. So if they're CO2 more, by far, this is the most, I would say, easy or somewhat easy and less stringent criteria than what we have for the, that we have for the hypoventilation syndromes and the COPD. So, by the way, so FVC less than 50, I said nocturnal desaturation, daytime hypercapnia more than 45, MEB less than 40. And when you have MEB less than 40, so that indicates weak cough, strength. So your cough response is weak, so you'll most likely have trouble dealing with secretions. And MIP less than 60, so that means anything like 50, 40, minus 40, 50. So that indicates global inspiratory muscle strength. So that gives you a hint as well. And sniff also, I mean, it basically gives you like the, the impression about your diaphragmatic weakness. But if you want to get some kind of sense about the inspiratory muscle group as a whole, then you order the MIP. Or if your vital capacity is less than, 15 to 20 ml per kg ideal body weight. And by the way, that's validated only for GBS. It doesn't apply for the rest of, other neuromuscular disorders. And significant orthopnea, because these patients don't get the orthopnea confusing someone with neuromuscular disease with heart failure, because this is a very significant symptom, because patients who have orthopnea and neuromuscular disorders, so they are at more risk of having, respiratory failure and requiring the need to be intubated. So this is per se, so it should be, and I'll show you in a couple of seconds that why it's not part of the guidelines side, sadly, especially with the CMS, but it has been proving with the research that it correlates with the progression of the respiratory failure in these patients. So in ALS, and most of the data is coming from ALS, if you start early, the earlier, the better. NIV can improve your, this is a question, by the way, you'll get on your board. So a pulmonary board improves your quality of life, improves the survival if applied early. And if you see on the actually diagram here, with FVC more than 65 people, when it was started with FVC more than 65, I think in that study it was less than 80 plus symptoms. So more than 65, they had better survival. If you wait until it's less than 65, then you know, the survival is less, okay? But if you see, I said FVC of 50. This is what, you know, they have. If you wait so long, then even starting the NIV is not gonna, you know, provide the patient with some kind of survival benefit and delay the progression of their neurological disease or whatever.
Just overnight or 24/7?
No, I'm talking, we're not talking about 24/7. This is for the overnight. This is for the nocturnal. Good question.
So we wait until it is 50 to qualify them? If the
I mean,
other criteria
you
is
don't
negative?
have to, but I mean, if they meet one of the other criteria, no, you don't. Yes, and here, so this is the CMS. What I told you is what is known from evidence that we have evidence for, okay? So this slide, don't get it confusing. This is the sum up of all the indications for, you know, home NIV, nocturnal NIV, and, you know, thoracic restrictive disease. If you meet any one of them, you should be on, based on evidence, on some nocturnal, okay, home NIV. And then this comes to, you know, applying this to what you have, especially if the only thing that the patient will get the equipment to be approved through the CMS, then you look at the guidelines. Number one, you have to have a documentation and the chart that you have thoracic cage abnormality or neuromuscular disease, okay? And by the way, what I noticed when I was preparing for this, they don't cover all medical problems that can cause neuromuscular disease. Like if you have spinal cord injury or phrenic nerve injury, it's not listed among the conditions that they think they are coverable. Don't ask me why. I mean, and those patients, they have more, actually, in my mind, chance of, even if they need this machine or they need to be on the vent, at least they can live longer than the ALS, where they will die no matter what you do. It's just maybe you buy them a few more months and maybe improve their quality of life. But the home vent is a palliative measure for ALS. It's not a curative. It's different from someone who had RTA and they have this problem. So it doesn't include everybody, the CMS list, but you have to have a documentation. And then also you have to have either ABG that shows more than 45, or you have, you know, evidence of, you know, nocturnal desaturation during sleep, okay? You don't have to have a sleep study, just only overnight pulse oximetry. And if you have neuromuscular disease, this is when you use your FVC and use your sniff and MIB and stuff like that. So this is not like for thoracic cage abnormality. This is in particular for neuromuscular, actually, disorders. Yes. And you have to, COPD does not consider to be a main player here. So you have to provide that in the documentation. First, they have a problem for which we think that they have thoracic, you know, a restrictive disease. Then you have to meet either one of the criteria that I showed you. Plus, you have to tell them that, okay, COPD is not contributing to the respiratory failure. If you see like the last, you know, column, it's flexible. You can use BiPAP or you can use AVAPs, you can use BiPAP-ST. So it's less stringent than the, you know, other hypoventilation syndromes or the COPD. But again, so the challenges that we have is the same thing. So there is a delay in the implementation of NIV. If you want me to wait until, you know, the FVC is less than 50, because it has been proven by studies that it's still working, but it would have worked better if we started earlier. They still want you to do all kind of testing, but believe me, if you have someone with, you know, muscle weakness and they are on wheelchair and they have limitations, then they need to travel to another place where they can have PFT, MEB, stuff like that, especially like if their CO2 is not elevated more than 45, then they have to do this based on this. They have to do the MEB, they have to come to PFT. Sometimes it's very hard to get them, especially like if they don't sit or something in the, in the PFT lab, and to fit in that, you know, glass box to have their PFT done. So it's a challenge. And this is, I don't know if you heard of this, is the mouthpiece, and I'll conclude with this. So whatever I told you earlier is indication to start an IV at night. I'm not talking about trach. I'm not talking about, you know, 24/7, you know, ventilatory support. But sometimes patients, they don't need, you know, to have a, you know, a trach, or they don't need to be invasively ventilated. But sometimes nocturnal NIV is not enough in thoracic, you know, restrictive disease. So if the FVC is less than 30, definitely they need some kind of home vent to be prescribed, not just only, AVAPs or BiPAP-ST, okay? So if you have, there is a need for NIV more than 10 hours per day. So this is a sign that they need to be on a home vent. And again, as I said, home vent doesn't mean that they need to be on a trach, but this machine that they need to be on, it's a home vent, not just only, AVAPs or BiPAP-ST. Or if their symptoms is worse during sleep, during talking, eating, during the day, they feel that they have daytime dyspnea for which they need to use some kind of NIV to help them during the day. If they need that, then they don't wear the mask, they can wear this, which is a mouthpiece, okay? So they wear the mask and, machine at night, and during the day they can, use the mouthpiece and the home vent for that as well. So I will conclude with this. Do you have any questions? It's confusing, but take it easy. So see obesity. So my message, obesity hypoventilation is common. I'm not saying very common, but it's common. I think we need to keep low suspicion to identify it, because treatment is not just only CPAP, because it can be something else. If we have someone who's been admitted acutely, even if for the first time, it's not great data, but I don't think that there is any harm if the insurance approves it. Why not? With raising the caveat that we need to do the sleep study within 3 months, because it will be challenging, believe me. But to send them they will meet their pulmonologist after 6 months, and they will order the sleep study after 7 months from that. So this is more than 1 year plus. So this is why they keep coming to the hospital. Discharge them, different from COPD. Make sure that you understand that there's different clinical phenotype for obesity hypoventilation. And sometimes don't be tricked by the absence of sleep apnea. And when it comes to the muscle weakness, thoracic cage abnormalities, I think the criteria is more flexible than the others. Just keep in mind that the disease, it depends on the disease process. I think everything will be individualized. If you have ALS as opposed to have, kyphoscoliosis, as opposed to having, neuromuscular disease, like myasthenia gravis, improving on treatment. You may need the treatment now, but if your disease is under control, you get better, you may not need it later. So it's a completely different, world when it comes to the, thoracic restrictive disease. Okay. All right. So legit to give people AVAPs when they have obesity hyperventilation, but not with COPD at least. And the data is weak in both sides, but at least for OHS is more solid. All right.
Why AVAPs is not like home? I know it is more volume target pressure, but why they don't consider it as home vent like the
Why?
trilogy?
I didn't get your point.
I mean,
So,
why the
trilogy.
AVAPs is not home? AVAPs is not home vent.
Because home vent, you need to have sometimes to offer all the kind of PRVC, and offer like volume controlled assisted mode.
Yeah, but mainly on the trilogy, we put them on the IPAP,
Yes.
EPAP, and the
System غبي.